Buenas tardes, bienvenidos a esta Conferencia Internacional del Colegio de Pediatría de Nuevo León. Me es muy grato saludarles nuevamente y tener la atención de todos ustedes, a quienes les ofrecemos la más cálida de las bienvenidas a esta sesión internacional transmitida en tiempo real desde las oficinas del Colegio de Pediatría de Nuevo León en Monterrey. Saludamos con mucho afecto a quienes se conectan y a quienes siguen esta transmisión desde diferentes lugares en la República Mexicana y también a quienes lo hacen desde diferentes ciudades de la Unión Americana, desde Centroamérica y desde Sudamérica. Saludamos también con mucho afecto a todos nuestros amigos y colegas de los diferentes colegios estatales de pediatría en todo el territorio nacional y que están afiliados a la Confederación Nacional de Pediatría de México. Un saludo muy especial a la doctora Marisol Millán Lizárraga, actual presidente de la CONAPEME, y al doctor Jesús Gerardo Guajardo Treviño, presidente electo de la misma. En el Colegio de Pediatría de Nuevo León estamos muy interesados en mantener el programa de educación médica continua a la vanguardia para poder proveer y brindar a la comunidad pediátrica y a sus especialidades afines actividades académicas de muy alta calidad que nos incrementen el conocimiento en las diferentes áreas relacionadas a la salud del niño. Quiero públicamente hacer un reconocimiento a todos y cada uno de los miembros del Consejo Directivo que me honro en presidir por el esfuerzo en planear, organizar y desarrollar un programa académico con muy alta calidad clínica científica. Para la realización de esta sesión académica, contamos con la colaboración de una organización con gran prestigio internacional. Y estoy hablando de Children's Hospital of Philadelphia. Nosotros agradecemos infinitamente las atenciones que hemos tenido para nuestro colegio de parte de Víctor Negrón, a quien saludo con mucho afecto y a quien le enviamos un abrazo de parte de todo el consejo directivo del colegio, por todas sus atenciones dadas a nuestro colegio y por facilitar que tengamos nosotros esta colaboración con instituciones de muy alto prestigio. Víctor Negrón, buenas noches, te agradecemos nuevamente tus atenciones y voy a cederte el micrófono y la cámara para que nos des un mensaje. Adelante, Víctor, muchas gracias.
Sí, buenas noches, un saludo cordial al consejo directivo, doctor Luis Gerardo, al doctor Juan Manuel, quien con mucha dedicación hemos entablado una buena amistad por muchos años y creo que a buena hora se nos dio la oportunidad de colaborar en este foro y creo que esta es la primera de muchas futuras de colaboración con el Colegio de Pediatría de Nuevo León. Quiero brevemente mencionar que el Hospital de Niños de Filadelfia lidera con la parte de educación y es parte de nuestra misión el poder colaborar con contenido clínico, contenido de investigación con otros médicos, especialmente como lo estamos haciendo ahora aquí con Nuevo León y médicos de México. Estamos en toda la disposición para ayudarlos, aquellos que quieran venir a nuestro hospital a hacer rotaciones, que necesiten alguna colaboración con algún médico, alguna conexión, estamos en toda la disposición de poder enlazarlos. No quiero abundar más porque creo que el video que tenemos a continuación se realizó durante la pandemia y creo que es algo que cuenta la historia y quiénes somos en el Hospital de Niños de Filadelfia. A continuación les quiero presentar un video que depicta todo lo que somos en el hospital. Si por favor lo pueden presentar el video, y gracias nuevamente.
Somos CHOP y no podemos esperar a mostrarles quiénes somos. Somos el primer hospital para niños del país. Ahora, una red de cuidado de la salud con más de 50 ubicaciones que sigue expandiéndose. 3 edificios de investigación de última generación con 1,5 millones de pies cuadrados de espacio. Hemos crecido de 12 camas hace 165 años a casi 600 camas y a ser uno de los mejores hospitales para niños en el mundo. Tenemos un centro de trauma nivel 1, 11 pisos de unidades para pacientes, más de 20 quirófanos, una unidad de parto para bebés con defectos congénitos primera en su clase, una suite de operación y cauterización cardíaca separada, así como lugares para el aprendizaje como nuestro reconocido centro de simulación. Hemos entrenado a generaciones de líderes en el campo de la pediatría. Somos líderes mundiales en medicina, cirugía y ciencia y uno de los principales receptores del financiamiento de los Institutos Nacionales de Salud. En este edificio, pioneros en la terapia CAR-T, enfermedad mitocondrial, tumores cerebrales, hiperinsulinismo y otras enfermedades poco comunes. Aquí se realiza un trabajo de vanguardia en cirugía fetal, genética y genómica y neurología. En nuestro edificio contamos con líderes en determinantes sociales en la salud, informática y epidemiología clínica, autismo, prevención de traumatismos y heridas. Nuestros pacientes vienen de todos los estados y de 115 países. Superar estos desafíos requiere de los mejores y más brillantes expertos. Nos apasiona la pediatría. Nos motiva poder hacer la diferencia en el mundo y en nuestra comunidad. Somos un equipo. Somos CHOP.
Sin duda alguna, una gran institución, Children's Hospital of Philadelphia. A toda la audiencia les comento que en breve empezaremos ya la conferencia del doctor Maqbool y les pido que quien quiera escuchar la conferencia en el idioma original, que es el inglés, lo seleccione en su botón para el idioma inglés. Quien quiera escuchar la conferencia en español, lo haga con el botón correspondiente. Thank you, Victor, again for facilitating the participation of children of Hospital of Philadelphia with a very important topic in the context of pediatric gastroenterology to be presented by one of the most important leaders in the field worldwide, Dr. Asim Maqbool, to whom we express our very special gratitude since we know that he is a person with many clinical, teaching, and research activities, having accepted the invitation to share his knowledge and experience with the Colegio de Pediatría de Nuevo León. Here is a brief curriculum summary. Dr. Maqbool completed his medical studies at George Washington University in Washington, D.C. He did a pediatric residency at Children's Hospital of Michigan, Detroit. He completed his fellowship in Pediatric Gastroenterology and Nutrition at Johns Hopkins Hospitals, Baltimore. Nutrition research in Bloomberg School of Public Health, Johns Hopkins University, Baltimore. He has completed special training and is certified in pediatric gastroenterology, pediatrics, physician, nutrition specialist. He is currently working in attending physician, co-lead Aerodigestive Center, interim nutrition fellowship director, co-director at Center for Pancreatic Disorders, associate professor of clinical pediatrics, Perelman School of Medicine at the University of Pennsylvania. He is co-medical director of the Center for Pancreatic Disorders at Children's Hospital of Philadelphia. Author and collaborator of many papers in different indexed issues and so many chapters of books as Nelson's Textbook of Pediatrics. A lot of thank you to be with us, Dr. Maqbool. Please.
Thank you for having me.
Please ahead with your conference, Pancreatitis and a Challenge in the Pediatric Age.
Thank you. Thank you for having me. I'd like to review pancreatitis in pediatrics. I would like to start by providing you an overview of pancreatic anatomy, physiology, and roles in digestion, as well as absorption. I'd like to review the pathophysiology of pancreatitis. I'd like to review the etiology of pancreatitis. We should also discuss clinical aspects of pancreatitis and the definitions that we use at present for pancreatitis. And lastly, I want to sort of talk about how we evaluate and manage pancreatitis, old approaches and newer developments, because I think the field is rapidly evolving in important ways. So I'd like to take a step back and go to pancreatic embryology to show you that the pancreas has two buds, a ventral bud and a dorsal bud. And they're on either side of the aorta. And somewhere between week 6 and 8, the ventral bud will rotate behind the aorta and fuse with the dorsal pancreas, and the ducts also fuse. And this is a very important part of pancreatic ductal development. What happens during this time is when the ducts fuse, you have one duct that will usually be predominant and the other one takes a minor role or disappears. If a duct does not fuse properly or persists in an abnormal way, then that is what we call a pancreas divisum. And I think that's very important for us to know. So in the top picture here, we have sort of the normal fusion. And in the bottom picture, we have absence of fusion, which is what we call a divisum. Oftentimes, the way that the duct fuses, the duct comes and fuses with this portion here of the ventral pancreas, and this becomes your major duct. The minor duct persists in maybe 30% of cases. It is this major duct that fuses with the common bile duct and empties into the duodenum. The pancreas divisum is not a single entity. It is an amalgam of entities that can present. And the fusion patterns are somewhat different. And that's illustrated by the picture here. And so there are a number of different kinds of divisum. It's basically it's a deviant of normal, and there is an occurrence that occurs in the general population. I'd like to remind you that the endocrine and exocrine pancreas have arrangements. So the endocrine pancreas are your islet cells, which are very rich and vascular. The exocrine or digestive pancreas consists of these acini and these ducts, which empty into the pancreatic duct and into the duodenum. The acini is where your proenzymes and your enzymes are made. The ducts are lined with cuboidal epithelium where your fluid and electrolytes are secreted from. So this is the business end of the digestive or the exocrine pancreas. This digestive pancreas is under both endocrine and neurocrine control. In terms of the endocrine control, CCK and secretin stimulate the acini, whereas the ducts are predominantly stimulated by secretin. The enzymes are then, pancreatic enzymes then are evacuated into the duodenal lumen. They are present in their inactive form, and they're activated by brush border enzymes into their active moieties and eventually degraded in the same way. The ducts also produce, in terms of fluids, they produce chloride and bicarbonate, which helps neutralize stomach acid. This altered pH helps to inactivate gastric pepsin and also provide the proper pH balance for improving fatty acid and bile acid solubility, and for these brush border enzymes and pancreatic enzymes to work optimally. So the pancreas is not only responsible for digestive enzymes, but also for acid neutralization and correction of pH, which is a very important concept with digestion and malabsorption. So when we talk about pancreatitis, we generally talk about it in two forms. There's an acute form, which is acute inflammation, abdominal pain, and elevated pancreatic enzymes in the serum. And usually this is self-limited. In other words, it runs a course and then it stops. Chronic pancreatitis involves chronic inflammation and chronic pain, and leads to the progressive loss of digestive function and eventually of hormonal or function as well, which renders it risk for diabetes. So let's talk a little bit more about the pathophysiology of pancreatitis. So usually you have an acute triggering event, and what happens is these pancreatic enzymes, which are meant to be released and activated in the duodenum, are actually activated in the pancreas itself. They overwhelm defenses, and you have more and more release of enzymes, which damage the cells, cause circulatory issues within the pancreas, lead to the production of pro-inflammatory cytokines, more vascular permeability, and then you have hemorrhage and thrombosis, eventually leading to fibrosis. And the cycle runs a course before it stops, and the damage is done. The most common etiologies in childhood include trauma. So usually we talk about bicycle injuries or handlebar injuries or seatbelt injuries to the abdomen. We talk about infectious causes, with viral infections thought to be most common. Some enteroviruses in particular have been implicated. There may be structural issues such as the pancreas divisum that I had mentioned to you, as well as gallstones. Certain medications increase the risk for pancreatitis, which we will review. There are certain metabolic causes as well. And to this day, up to half of cases of acute first episode pancreatitis are idiopathic. So I mentioned plumbing to you. What's very important to understand is that when you have cholelithiasis and cholecystitis, they can involve different segments of the biliary tree. Remember that the left and right hepatic ducts empty into the common hepatic duct, where they fuse with the cystic duct and form the common bile duct. This empties at the head of the pancreas at the major papilla. Obstruction at this level will cause pancreatitis. So it's important to understand this arrangement also because a bout of gallstone pancreatitis does not automatically necessitate the removal of the gallbladder. You have to see where the stones are coming from. Oftentimes an MRCP or an ERCP will be performed to identify and flush out the crud and the stones prior to cholecystectomy. That's the course of action that is indicated. In terms of causes of pancreatitis, we mentioned traumatic disruption or obstruction of the duct, such as with trauma, where trypsin is activated where it should not be. Most of the mechanisms for activation of these pancreatic enzymes involve hyperstimulation of calcium, and that activates trypsinogen within the acini. There are three major types of genetic causes of pancreatitis, amongst many, that all basically act to activate enzymes or inability to inactivate enzymes within the pancreatic body. This includes your CFTR mutation, seen with cystic fibrosis, your cationic trypsinogen gene mutation, or the PRSS1 mutation, which is autosomal dominant, in which trypsin cannot auto-inactivate. And then you have your SPINK1 mutation, which is activated trypsin within organ as being unchecked. SPINK1 is neither autosomal dominant nor autosomal recessive, and often it is present in combination with other things, such as a pancreas divisum. The metabolic causes include propionic acidemia and methylmalonic acidemia most commonly. Mitochondrial disorders can present with pancreatitis. Connective tissue disorders can present with pancreatitis. So we have to be aware of those. And then hypertriglyceridemia has been associated with pancreatitis, although the precise mechanism is unknown. So we have to think about what causes the insult, and we've mentioned some of these etiologies. When we talk about hypertriglyceridemia, we're talking about triglycerides greater than 1,000 milligrams per deciliter typically. Autoimmune disease is less common and rare, but there's increased recognition for this. So when you look at sort of the breakdown of cases, pancreatitis seems to be more common than the sphincter of Oddi dysfunction, than the pancreatic duct malunions, than gallstones or other causes. And in terms of toxic exposures, tobacco by far is the leading cause, followed by hypertriglyceridemia, medications, metabolic diseases, and alcohol intake. So we have to think about all of these things, even in our pediatric patients. Tobacco exposure may be secondhand. It is not unheard of that children may drink alcohol. Regardless of the underlying genetic cause, for example, as I mentioned to you before, the activation of trypsin where it should not be activated and the inability to break it down or to flush it out is what is the genetic or hereditary basis to some forms of recurrent or chronic pancreatitis. The PRSS1 mutation by far and above is the most significant genetic abnormality. It is autosomal dominant and increases lifelong risk for pancreatic cancer. So it's important to know about this if you have a case of recurrent or chronic pancreatitis. SPINK1 mutations are second most common, neither recessive nor dominant. CFTR mutations are the third most common, and then the CTRC ones are the fourth most common. And again, these may vary by population, so that's something that you should be aware about. Okay. In terms of comorbidities, this was a study performed at Yale, New Haven, in Connecticut, in which they looked at a 13-year experience of pancreatitis in their hospital of acute pancreatitis. And there were certain comorbidity conditions associated with seizure disorders and ALL more common, inflammatory bowel disease, transplant patients, patients with HIV or asthma, renal disorders, AML, identified in a significant number of cases, with only 6% of cases not associated with any other underlying issues. In terms of the medications, steroids far and above were the most common medications associated with pancreatitis. But in addition, you'll see valproic acid or Depakote with very high incidence. You see methylamine, Bactrim, or trimethoprim sulfamethoxazole, 6-MP, asparaginase, erythromycin, and vincristine among the more common medications. Also cyclosporin, metronidazole, acetaminophen have been reported. So medications we have to think about very carefully and what their risk benefit is in our patients. We often talk about focusing on the history and the symptoms, on medication and trauma. Family history is very important if you're thinking about hereditary causes. And on the exam, you think about tenderness, particularly in the epigastrium. You think about jaundice for an obstructive etiology, such as gallstones. And then you look for Turner's or Cullen signs. I think it's also very important to think about younger children. And we tend to think about these classical symptoms in children and adults, but in truth, you may not have very obvious symptoms in younger children. And abdominal pain, epigastric tenderness, and nausea and vomiting may be absent in very young children, particularly in children between the ages of 0 and 2. And in those patients, you have to be very careful to ask the right questions, but also to have some index of suspicion for pancreatitis, particularly where there's a family history of it. And sometimes investigations for pancreatitis are indicated in those families where there's a family history and a patient seems to not be presenting with obvious or overt symptoms. Their symptoms may be very mild and nonspecific. Here I have pictures of Cullen sign and Gray-Turner sign where you have this purplish discoloration around the umbilicus or in the flank related to hemorrhage. So it's always important to look at the abdomen and also roll the patient to look at the back of the patient. What about labs? When we do an assessment, we think about amylase and lipase most common. So amylase peaks at 48 hours. It usually is elevated for up to 4 days. There are false elevations present in a variety of conditions, including small bowel obstruction, mesenteric ischemia, tubular ovarian disease, and renal insufficiency. There are at least 5 different isotypes of amylase, so sometimes fractionating it may be helpful if it's elevated and you don't know what the source is. Lipase seems to have higher specificity than amylase. It stays elevated for 8 to 14 days longer than the amylase. But lipase, again, is not unique to the pancreas. There's gastric lipase as well as lingual lipase. Unfortunately, fraction dating lipase is more of a challenge and is not routinely done. In young infants, you have to think about gastric volvulus as well as a potential source of elevated lipase. We frequently look at hepatobiliary labs as well, because as I mentioned, gallstone pancreatitis is fairly common as an etiology in children. We have to think about serum triglycerides, and we have to think about serum calcium levels, as well as urine calcium excretion. And then genetic testing is to be considered if there's a relevant family history or if this is about a recurrent or chronic pancreatitis, even if you have an anatomical abnormality. You would be surprised to see how many patients with pancreas divisum actually end up having SPINK1 genetics as well, which may be contributory. In terms of imaging, ultrasound is always the first line. It's very good to determine altered echogenicity. It's a fairly good measure to look at the ducts and to look for gallbladder sludge and stones. It may be useful to determine if there are calcifications present. And sometimes it gives you the first hint of colodocal cysts. We often use ultrasound as a modality to follow fluid collections as well. Now, historically, we've moved to CT as second line, and it really is the best modality to look for calcifications. However, CT scans do incur a lot of radiation. So we tend to shy away from them a little bit more now than we used to in the past. We'll use MRCP a little bit more, and it usually gives you very good detail about the ducts and malformations. And you can usually draw inferences to determine if there are calcifications or not. Less commonly, we'll talk about ERCP, but there are roles for ERCP if we have unexplained recurrent or chronic pancreatitis, if there are concerns about duct disruption or strictures, and has therapeutic in potential that you can flush out the ducts, for example. You can do a sphincterotomy, you can place stents. There are things that we can do that this is useful for. Now, the definitions of pancreatitis have evolved over time, and I think this is something I wanted to spend a minute or two talking about, is that we all have to sort of be speaking the same language and defining pancreatitis in a very similar way. So in terms of acute pancreatitis, INSPIRE is a multinational consortium dedicated to the investigation and management of patients with recurrent and chronic pancreatitis. And these are the criteria that were proposed by INSPIRE 9 years ago and that are used mostly around the world now. So for acute pancreatitis, you need 2 out of 3 criteria. You have to have sort of the classical abdominal pain, which is abdominal pain, usually acute of onset, usually epigastric, and usually it radiates to the back. You should have amylase or lipase activity greater 3 times than the upper limit of normal. And then you need to have imaging findings characteristic or compatible with acute pancreatitis. And you have a variety of choices there. You have to realize that after some time, the pancreas, after recurrent bouts of pancreatitis, may not mount as much of a lipase response. And that's one of the reasons why you need 2 out of 3 criteria that are listed. That was the rationale. We talk about pediatrics as being less than 19 years of age. To talk about recurrent, we want 2 distinct episodes of acute pancreatitis, and we want an interval of complete resolution of pain 1 month between these 2 bouts, and or normalization of the enzymes before the subsequent bout is diagnosed. So the interval of time there is very important when we talk about recurrence. In terms of chronic pancreatitis, you need one of the 3. You need sort of consistent pain and imaging findings suggestive of chronic damage and often irreversible damage. You need some suggestion of digestive or exocrine pancreatic insufficiency or a surgical or pancreatic biopsy demonstrating sort of fibrosis. Again, the biopsies are done much less commonly because it is fairly invasive and not without risk. So chronicity of pain, imaging changes, and evidence of digestive or exocrine pancreatic insufficiency are the criteria for chronic pancreatitis. Now, in adults, they use something called the Ransom criteria to as a pancreatitis score, and investigators and clinicians have spent some time trying to come out with pediatric scoring systems as well. There's something called the pancreatic acute pancreatitis score, or the PAP score, which looks at weight, age, white cell count, LDH, calcium, albumin, fluid, and BUN. and this is one modality that has been in use. The sensitivity is 70% or so. The specificity is about 79%. The negative predictive value is higher than the positive predictive value. The WBC count, the calcium, and the BUN seem to be independent predictors. And I would like to point out that BUN in particular, greater than 13 plus minus an albumin, is thought to be predictive of a risk for progression to severe pancreatitis. And this is sort of data that was presented from my colleagues from Cincinnati in the last 6 months. So BUN can be an important prognostic indicator and something I urge you to pay attention to. The problem with pediatric pancreatitis scores is many of the earlier scores have really emphasized CT score findings, including pancreatic enlargement, inflammation, fluid accumulations, and extent of necrosis. The problem with these is that they require CT, and we've really moved away from CT as an imaging modality if we can help it. So something to keep in mind. Serum lipase greater than 7 times the upper limit of normal at the initial presentation may be suggestive of risk for severe pancreatitis as well. The limitation of this study is typically you won't see this outside of a first or second acute bout because you will have some glandular damage and loss of function that may be subsequent, and you may lose this predictive marker, particularly following the first few bouts. So I present this slide, but I think it's important to know what the limitations of this data may be. There are other sort of severity measures that INSPIRE has come up with. They relate to organ dysfunction, and that can include cardiovascular function, renal function, or pulmonary function. If dysfunction is present, the question is it transient or not? If it's not transient and it lasts greater than 48 hours, you're at risk for severe pancreatitis. If the organ dysfunction is transient and responds well to supportive therapy and resolves within 48 hours, then you may be in the moderate category. If you've not had organ dysfunction and there are no local or systemic complications, then it may be classified as mild. So sometimes these diagnostic trees are helpful to us. And I think the important thing about INSPIRE to remember is pancreatitis is still considered to be a rare disease. And I think by having these kind of consortiums, there's strength in numbers from which we can draw better inferences than single site or single center studies, which may only have a handful of patients. Necrotizing pancreatitis, again, is mostly a diagnosis made on the basis of imaging. CT severity indices have not been validated in pediatrics, but we are concerned because necrotizing pancreatitis, at least in the adult population, is associated with increased morbidity and mortality, approaching 25%. We do not have the same experience in pediatrics. This is very rarely significantly increasing risk for mortality in pediatrics. The risk factors, again, are associated with severe pancreatitis, with significant elevations in amylase and lipase, greater than 10 to 19 times normal, respectively. Certainly, if you have coexisting conditions such as diabetes, ALL, or gallstones, or a bone marrow transplant, your risk may go up. Certain medication use may also increase the risk for necrotizing pancreatitis, as listed: minocycline, L-asparaginase, valproic acid, prednisone, and tacrolimus. And then acute complications can be systemic, including atelectasis, effusions, hyperglycemia, ascites, oliguria, DIC. And most patients do recover, although some may be at risk for acute fluid collections or for pseudocysts. Now, I would be very much in trouble if I did not share with you how we classify fluid collections in pancreatitis. Our radiologists are very particular about this. So you can have fluid collections as a function of inflammation. And we call these acute fluid collections if they are less than 4 weeks in duration. We classify them as pseudocysts if they last greater than 4 weeks. The same with necrotizing pancreatitis. The duration of the findings is important in how we define these as acute fluid collections versus pseudocysts or walled-off necroses. That is a very important concept. Time is of the essence, number one. Number two, the second point I'd like to draw is that not every fluid collection should be or needs to be drained. We need to give patients time for these fluid collections to resolve on their own. And we only drain them if they are symptomatic or they're infected or we think they're contributing to ongoing problems. Otherwise, we leave them alone. And this is best exemplified by an Indian study of pseudocysts. So these are fluid collections that lasted for greater than 4 weeks. And in 87 patients with acute pancreatitis, 58 children were enrolled from that study, of which more than half were classified as severe, and about a third were classified as being mild. Of the patients with mild fluid collections, only 10% had acute fluid collections, which resolved. So they did not require drainage, which is very important. Of the severe patients, 15% had no fluid collections, 84% had fluid collections. Of those 84%, almost 69% went on to form pseudocysts, whereas 31% did not. And eventually, only half of those patients with pseudocysts required an intervention, whereas half did not. So the overall drainage rate for pseudocysts was about 26%. So what I'm trying to tell you is, if there's a fluid collection, give it time, number one. Don't be in a hurry to drain it, number two. And number three, most of them tend to resolve on their own and don't require any intervention. Now, the time to resolution of the study, as highlighted here, was significant. It could be anywhere from 25 days to over a year. The question is it causing any symptoms such as pain, discomfort? Is it contributing to inflammation? Is it organizing into an abscess? Those are the kind of questions we have to be asking ourselves. The complications, I mentioned the necrosis, I mentioned fluid collections. Hemorrhage can occur, particularly if you have L-asparaginase-related disease or trauma. Abscesses and sepsis are also complications that may arise or occur at times. In terms of systemic effects, you can have ascites, you can have pleural effusions, you can have fistula formation, you can have a systemic inflammatory response, and multisystem organ failure, particularly in severe cases. So we take pancreatitis extremely seriously for these sort of concerns. In terms of management, I wanted to sort of shift gears here a little bit and talk to you a little bit about how management has changed over the years. Anecdotally, we used to talk about resting the pancreas, which means making patients NPO, giving them IV fluids, putting them on low-fat diets, and using opioids to manage pain. There has been a paradigm shift in how we manage pancreas, which has trickled down from the adults, but has also been validated now in pediatrics, that we have to focus on recovering the pancreas. And I'm going to talk to you about exactly how we do that. So there are 3 principles of pancreatitis management in 2021. The first is early, aggressive, and appropriate hydration. The second is early enteral feeding. And the third is appropriate and adequate pain management. And I think these are all very important concepts. In terms of fluid resuscitation, this mostly comes from adult data showing that early hydration, particularly within the first 24 hours, is very important. Oftentimes we'll run fluids at 1.5 to 2 times maintenance. You have to be careful to start this early and not sort of in the middle of a bout, because delayed hydration may actually be counterproductive based on one Chinese study. So we're usually talking about 1.5 to 2 times maintenance. So the volume is important. The second part of this is what fluid to use. The resuscitation fluid that we most typically have used has been normal saline. However, there's adult data and now pediatric data that suggests that using lactated ringers, or LR, reduces the systemic inflammatory response in adults. And the pediatric data seems to support this. So using LR, if available, instead of normal saline is an emerging and important concept. And these measures have reduced in-hospital mortality in adults and in children, as reviewed by Tim Gardner in 2009 in pancreas. So early hydration, appropriate hydration, and following fluid status is very important. In terms of nutrition, early nutrition is important to help maintain mucosal integrity. It's important to reduce the risk of bacterial translocation and reduces the risk of production of inflammatory cytokines. It also stimulates gut motility because, as you know, when you have an inflamed pancreas, you can have acute or chronic worsening of GI motility, and constipation can be a confounder with the pain. Early feeding also maintains intestinal flora and decreases bacterial translocation, which is thought to be one of the etiologies of sepsis and systemic inflammatory responses. Now, when I talk about enteral feeding, we talk about feeding orally, if possible, and we do not restrict what we feed children. We talk about feeding nasogastric tube feeding within 48 hours of admission, and NJ feeds if no other measures work within 72 hours of admission. These measures have been shown to decrease morbidity, mortality, and length of hospital stay in pediatrics and in adults. Also, one more concept here that's very important is historically we focused on a low-fat diet. There's no evidence that a low-fat diet is needed or required, particularly in the long term for patients with pancreatitis. In terms of pain management, we should focus on non-steroidal anti-inflammatory drugs and acetaminophen as first-line medications. We are able to escalate along the NSAID pathways if needed. And opioids do have a role to play in pain management, but typically only over the first 3 days. And after that, we have to talk about other modalities of pain. I also mentioned that it's important to recognize confounders of pain and to address them, including altered GI motility, ileus, and constipation. Sometimes we treat pain with opioids, which exacerbate constipation and dysmotility, and then we keep increasing these medications, which worsens the dysmotility and doesn't actually address the underlying problem. Chronic pain requires more neuropathic agents. Amitriptyline, gabapentin, for example, can be used. Physical therapy for desensitization can be used. And integrative health, including yoga, physical therapy, acupuncture, and hypnosis have also been used successfully. We also have a cognitive behavior therapy model and an online module that can be used for chronic pain. What about antibiotics and probiotics? Currently, they're not recommended for routine use in uncomplicated acute pancreatitis, and we reserve them for sepsis in the presence of positive blood cultures. The problem with pancreatitis is that if you have sepsis, it's usually polymicrobial, and you usually need antibiotics to cover those bugs, and only if you're acutely sick. Using antibiotics independently can actually lead to superinfections and fungal infections in particular. And sometimes you may need to consider adding an antifungal agent if you're using antibiotics. We do not use antibiotics for prophylaxis prior to ERCP or sphincterotomy. Instead, we use rectal indomethacin. Certain medications can induce pancreatitis that you have to be aware about, including INH, rifampin, and doxycycline. So you have to be careful about antibiotics causing pancreatitis. What about probiotics? Probiotics are used fairly liberally. However, probiotic use in acute pancreatitis is contraindicated as it does not reduce morbidity and has been associated with increased sepsis and bacteremia, sepsis, and mortality. So if you have acute pancreatitis, I would recommend not to use probiotics. They're actually detrimental in the setting. One of the few conditions in which they're not helpful. What about pancreatic enzymes? So pancreatic enzyme replacement therapy has been postulated for many years or many decades now to be that they may be helpful in preventing pancreatitis or reducing pain in pancreatitis. And there are exactly 5 studies that have been performed using enzymes and pain response in bouts of pancreatitis. And what happens in pancreatitis is your pancreas almost goes into reset or reboot mode. And you may have a transient decrease in your digestive enzymes. But over time, those may come back up and normalize. Of the 5 studies done, 3 studies were performed with coded enzymes, and 2 studies were done on non-enteric coded enzymes, in other words, with Viocase. And the patients who had the non-enteric enzymes seemed to have a clinical response, where those with enterically coded enzymes did not. However, there's a caveat for this in which the investigators did not quantify or document that there was exocrine or digestive pancreatic insufficiency in the patients with uncoded enzyme use. So that could have been a confounder in the study. So at the present time, there's really no evidence to use pancreatic enzyme replacement therapy to manage pain unless you have evidence of exocrine pancreatic insufficiency. so we don't use it routinely. So what are the indications to use enzymes in 2021? If you have transient or permanent exocrine digestive insufficiency, then you can use them to manage that in particular. I think we have to get out of the habit of just checking fecal elastase once and saying, okay, you have exocrine insufficiency and never checking it again, because it can resolve. It can take weeks, days, months, sometimes years to resolve. We do not use enzymes for routine pain management. We need to address fat maldigestion and fat malabsorption in particular. There's no evidence that PERT reduces risk for reoccurrence of pancreatitis. There's really no literature, there's no data. It's just done anecdotally and we don't recommend it. And then we know that enzymes are not benign, because we know that from our experience with CF that there's a ceiling to how much enzymes you can use, after which you increase the risk for fibrosing colonopathy. So we try to shy away from these as best we can. I wanted to introduce you to some new tools we have available at CHOP, and that you should be able to access. These are open source content. We have a clinical pathway that we have formulated that is helpful in decision making for you to use pancreatic enzymes and when to use them. It kind of walks you through the indications, the measurements, how to use them, when to use them. So I think that's a useful tool that we have for you. Usually we think about these when you have steatorrhea, which is grease in the stool, not floating stool. Remember that stool can float for a variety of different reasons, and you really need to think about grease in terms of fat droplets or oily stool as what steatorrhea compromises. Why do we worry about exocrine insufficiency? Because you can have associated fat-soluble vitamin deficiencies, essential fatty acid deficiencies, as well as multiple micronutrient deficiencies. So we have to remain vigilant about these nutritional deficiencies. These deficiencies can be very subtle, they can be very subclinical, and therefore if you don't think about them, you may not actually detect them, and they may have lifelong irreversible consequences, such as for bone health or cognitive ability, for example. Assessment can be via direct pancreatic stimulation testing, the old drilling tube method, or now endoscopic pancreatic stimulation testing, which is gaining traction, although it's not standardized. The indirect testing are sort of looking at the surrogate markers. So we can look at stool elastase, for example. We can look for the fat-soluble vitamins and essential fatty acid status. Those are the measures we would typically think about. Management, again, is the enzyme replacement therapy, fat-soluble vitamin supplementation, and other micronutrients if or as indicated. There are a number of emerging tools that I would draw your attention to. ESPGHAN and NASPGHAN Pancreas Committee publications have been increasing over the last few years. There's a 2017 JPGN manuscript on the management of acute pancreatitis. There's a nutritional management of pancreatitis publication in JPGN from 2018. And then there's a trio of papers that have actually just been published or in the process of being published that look at the medical, imaging, and surgical management of chronic pancreatitis that I would draw your attention to. And these are very good resources and reports that I have contributed to with my colleagues, and we have really reviewed the literature and present the best possible evidence-based approaches to help improve care for children with pancreatitis. So I encourage you to look at those. The medical management manuscript actually goes through digestive or exocrine pancreatic insufficiency. It talks about pancreatitis-associated diabetes, or what we call type 3 diabetes. It talks about multimodal, multidisciplinary pain management. We have an analgesia ladder tool here, as well as some lifestyle aspects to this. This is the picture that we have, or the illustration we have about pain management, anywhere from acute intermittent abdominal pain all the way up to uncontrolled severe persistent abdominal pain. And it sort of goes over the medications, the age, the restrictions in great detail. So I would encourage you to avail of this resource when you can. We also talk about sequelae of chronic pancreatitis, such as those fluid collections I mentioned to you, about ductal disease, about vascular complications, about impairments in motility, risk for dysbiosis and small bowel bacterial overgrowth, as well as real considerations that we have to have, including that for pancreatic cancer, particularly if you have a PRSS1 mutation. In terms of emerging imaging modalities, in addition to the standard MRCP, there's now a secretin-stimulated MRCP study that we can perform that really helps flush out the ducts and visualize the ducts in a way that standard MRCP just doesn't give you. Secretin, remember, stimulates both the acini and the ducts, and they will dilate on the imaging, which is very helpful in sort of getting a good delineation. People have talked about using this modality as a functional surrogate marker for ductal function, although direct correlation with bicarbonate secretion has not been performed successfully to date. We tried to, this sequence of pictures shows injection of secretin into the vascular supply and subsequent flushing of the ducts and dilation and filling of the duodenum and jejunum following secretion. So it's a very nice, beautiful sort of imaging modality. But there are limitations to this. You should not do this during an acute bout of pancreatitis because, again, the pancreas is in reset mode and you may have a suboptimal response. You want to not do this if you have a known allergy to secretin. We want to not do this if you're on anticholinergics because that can interfere with the test. And you certainly don't want to do this if you have an obstruction because you're then stimulating against an obstruction, which can have detrimental effects, including duct disruption, pseudocyst formation, fluid leaks, etc. So it's a good test to do, but it is a surveillance test, not an acute diagnostic test. There are also new surgical approaches. So in terms of surgery, there are many surgeries that have been postulated and used before. One of the more common ones is, most of these surgeries have to do with enhancing drainage or removing diseased tissue. So one of the more important ones is the Pousteau, and the Pousteau basically takes the pancreas along its long axis, and then it flays it open along the pancreatic duct where my pinkies are, okay? And then what you do is you stitch that pancreas to the duodenum like this, and then you have continuous sort of drainage along the length of the pancreas. So this is a technique that's used if you have sort of ductal dilation and impediments to flow. You need your duct to be at least 6 to 7 millimeters in diameter to be able to do this. And this is something that is done commonly across centers. Resection of the pancreatic head is something that people have talked about, which is done, and you preserve the duodenum and the bile duct. Often you combine it with a Pousteau if you have a diseased head. And the most extreme or severe forms of surgery include resection of a significant amount of the pancreas, the head of the bile duct, the gallbladder, the duodenum. Sometimes also with a partial gastric resection. This is called a Pousteau procedure, and it's quite extreme. Now, if you were to ask me in 2021, if I have a PRSS1 mutation in recurrent pancreatitis, the treatment, of course, of choice is now evolved into something called a total pancreatectomy and islet cell autotransplant, or it's abbreviated TPIAT. And this is a very interesting kind of procedure. The indications for this are chronic pain. You want to do it while you still have a reasonable islet yield. And if you have a PRSS1 mutation, really this is the surgery of choice in 2021. What the surgery involves is that you have a pancreatectomy and a Roux-en-Y procedure performed, similar to what you would do for biliary atresia, as well as a splenectomy, most common. Now, after the pancreatectomy occurs and while the Roux-en-Y is happening and the spleen is being resected, the pancreas is taken to a lab and it is enzymatically and mechanically digested, and the islet cells are retrieved, isolated, and concentrated. And then before you close up the abdomen, these islet cells are injected into the portal vein, and they will migrate into the liver, and within 6 months or so, they start making insulin. So regardless, once you've had a pancreatectomy, you're going to need pancreatic enzyme replacement therapy. That's a given. But what this procedure does for you is that it allows you to make some, most, or all of your insulin within several months of the surgery. The success rates have to do with your islet cell load prior to the surgery, as well as age. So usually this procedure, when performed in children, is more successful than when performed in adults to prevent full-blown diabetes. You may have a little bit of brittle diabetes, but generally it's a very promising approach in pediatrics. Also, if you have a PRSS1 mutation and you remove the pancreas, you've essentially eliminated the risk for pancreatic cancer as you don't have a pancreas anymore. This procedure has been pioneered at Minneapolis St. Paul. They've done 484 TPIATs published in 2012. Within 6 months, 90% of patients were pain-free, and 65% or two-thirds had partial to full beta cell function, which is quite impressive. The clinical criteria that most favor this are hereditary pancreatitis, a younger age, and females tend to do better when you have earlier surgery. Factors that drive lower islet cell yield include fibrosis, how many years and bouts you've had of pancreatitis, your BMI, and what area you were transplanted with. Now, transplant surgeons will also tell you that if you've had a prior pancreatic surgery such as Cousteau, the fibrosis and the arrangement of the ducts may preclude from a successful TPIAT in terms of islet cell yield, as the vascularity and changes reduce the yield of those islet cells. So it's very difficult to justify a Cousteau leading to a TPIAT if that's where you're headed to in any case. I'd like to mention Inspire to you. Inspire is our international consortium that is dedicated to the study and improving care of patients with recurrent and chronic pancreatitis. There are 24 to 30 sites globally. This started as a retrospective observational study, which is now prospective and interventional. CHOP joined about 4 years ago. We now contribute the third highest number of patients to this collaboration. We're also part of the NASPGHAN and Pancreas Committee, and we've been involved with several studies and reports and ancillary studies, both at NASPGHAN, but also through Inspire, which are very important. We have developed tools at CHOP for you, including the PERT pathway I mentioned to you. We also have a pancreatitis clinical care pathway that we have developed at CHOP, in which we've standardized how we manage our patients based on the principles I gave you. Now, each of these pathways is very comprehensive. They have a lot of links. These are open source. So these are available to everybody anywhere in the world to access and to use and to modify to your own institution and programs, requirements, and needs. So I encourage you to avail of these, and I've got the links down below, but these are also available at the CHOP website. We also have open source patient family education on pancreatitis and fast facts on pancreatitis with our new approaches to pancreatitis mentioned. I'd like to show you our team, which is rapidly growing. We have gastroenterologists, endocrinologists, clinical psychologists, clinical nutrition, oncology, pain management, surgery, radiology, interventional radiology, and most importantly, our patient advocates who are involved with this program. And I would encourage you to contact us if you have any questions or concerns. We also have a very large Center for Congenital Hyperinsulinism at CHOP from monogenic diabetes. And Dr. Adzik has performed well over 500 pancreatectomies in children, the most of any surgeon anywhere that I know of. So we do have experience and expertise, and we do welcome your referrals and to collaborate and to help you improve the care of your patients. But what I'm trying to show here is it's more than just a gastroenterologist being involved in this process. You really do need an infrastructure and a team to take care of these very complex patients. And believe it or not, all of these disciplines were involved in our clinical pathway development and in developing our programs. We're very happy to provide you with our contact information in terms of discussing cases, referring patients. We're very open to collaborating in any which way to help take care of our patients everywhere in the world. The pathway links are listed for you. They're free and they're easy to modify and to use. We also have a number of continuing medical education presentations, as well as one on pancreatitis for you to be able to refer to. And in summary, I wanted to say that we've moved away from resting the pancreas to recovering the pancreas, aggressive early hydration with lactated ringers, early reintroduction of feeds, and appropriate and adequate, but not excessive pain management are important parts of what we do. Pain management should be multimodal and not just rely on medications. We have to follow your BUN and your intake and your output. Pancreatic enzyme replacement therapy has its indications and its limitations. Really, the indication is exocrine or digestive insufficiency. It does not reduce risk of pancreatitis. It does not manage pain independent of maldigestion and malabsorption. And excessive or high dose use is known to have increased risks. There's research and there are opportunities to participate in research to inspire and the NAS began. And we have multiple resources and tools available for you at CHOP and elsewhere, which I encourage all of you to explore and to use. I'd like to thank my colleagues listed here who have worked with historically as well as currently, and I'd like to point to some of the resources I used for this presentation, and I'm happy to take any questions. Thank you.
Thank you, Dr. Maqbool, for your brilliant conference. And we have a few minutes for question and answer of the audience.
Yes.
¿Hay? ¿Con qué frecuencia? The frequency of the biliary duct cyst as cause of pancreatitis?
So that's a great question. Colodocal cysts can present with pancreatitis. Types 1 to type 4 can present with pancreatitis. And usually you need to have a colodocal cyst resection at a minimum, and sometimes something as significant as or involved as a Roux-en-Y procedure may be required. We also have to continue ongoing observation and surveillance for risk for cholangiocarcinoma in those patients. So I do tend to follow CA 19-9s in those patients as well. But yes, I have a number of patients who have had colodocal cysts and who have pancreatitis as well.
We have so many comments about so many people around so much cities, Mexico City, Guadalajara, Puebla. Excellent conference. Congratulations, Dr. Maqbool. No more questions, maybe. Which is the time or which parameter we have to know to start a feeding early?
So what I typically say is I do not stop patients from eating. So I will let them eat whatever they want, whenever they want, provided that they're not they don't have any organ failure or altered mental status. So if a child would like to sip on some water or sip on some juice or drink some milk, I don't have a problem with it. If they'd like to eat a regular diet, I have no problem with it. I don't recommend low-fat meals. I recommend, but I don't also say that you should not have a very high fried meal when you have a bout of acute pancreatitis. I usually try to start feeds within the first 24 to 48 hours. I try to do this by mouth first. If we're unsuccessful by mouth within 48 hours, we do NG tube feeding at a slow, continuous rate. And if they're unable to tolerate that, we plan for NJ feeds within the first 72 hours of an admission. So oftentimes when they're admitted, I may order an NJ tube because it takes 2 or 3 days to set that up. And it's always easier to cancel a procedure than it is to schedule one at the last minute.
Okay. In which cases or which age of the children do you recommend a Whipple?
So I think the Whipple procedure is a surgical decision, and it's based on the severity and the duration of pancreatitis. If you have a pancreatitis with where the pancreatic head is involved and is not draining, and you have significant fluid collections and morbidity and mortality, and you're unable to do anything endoscopically to change that course, then a Whipple may have a role.
Do you suggest to search genetic disorders in patients with pancreatitis and cyst of the choledoch?
So for a first bout of pancreatitis, in which there's no evidence or suggestion of a prior history of pancreatitis, and there's no family history of pancreatitis, I would not do genetic testing. However, if a patient has a first bout of pancreatitis and there's a family history of pancreatitis, then I will do genetic testing. And if a patient has had more than one episode of pancreatitis, or on initial imaging has evidence of prior pancreatitis, such as calcifications, then I would say they should be genetically tested, even if they have an anatomical abnormality. Because sometimes you can have more than one genetic abnormality or one anatomical abnormality or an anatomical abnormality plus a genetic abnormality that causes symptoms. I have several patients who have SPINK1 mutations, for example, and either choledochal cysts or pancreas divizum. So there may be more than one factor at play.
Which is the nutritional treatment in a patient with chronic pancreatitis, and when to start?
So it depends on what the cause is. If the patient has chronic pain and it relates to fat malabsorption, we typically would do a fecal elastase, provided that it's not loose stool. And if you have a low elastase, then that may be an indication to start. If you have more than 2 fat-soluble vitamin deficiencies, then that may be an indication to start. So vitamin D deficiency is very common, but having vitamin D and vitamin K deficiency is a little bit less common. And then having vitamin A or E deficiency is much less common. So if you have more than 2 fat-soluble vitamin deficiencies, and if you have a low stool elastase on form stool, and signs and symptoms like steatorrhea or gas, then I would think about starting enzymes. And that's where that clinical pathway that I showed you may be helpful in your decision-making process.
In pancreatitis, when it is considered as recurrent?
Recurrent would be if you've had a bout of pancreatitis 1 month after you've either had complete resolution of symptoms and normalization of labs. So the interval has to be at least 1 month. Otherwise, it may be part of the same bout of acute pancreatitis. And we have seen that before.
Another question. With the pancreatitis due to meds like rifampicin, do we have to stop completely these tuberculosis meds, or we should continue them in lower dose?
So that's a good question. I think it would vary by medication, and I honestly don't know the full answer to that. Whenever there's a substitute medication available, I would sort of err towards that. For example, if you're on an anti-seizure medication, then using a different anti-seizure medication may be beneficial. If you're on an antibiotic, using a different antibiotic may be beneficial. But I also recognize that for certain conditions like tuberculosis, you may not have a choice. And I don't know enough about those conditions to be very honest with you. But where there are alternatives, we should go for the alternatives.
Okay. Which is the better hydration? Enteral or IV?
I'm a big proponent of enteral fluid hydration, particularly at home. I think that adequate hydration may be an important tool in preventing recurrence of pancreatitis. If a patient is hospitalized, I will give them an IV bolus of normal saline. I will start them on lactated ringers, but I will not restrict them from drinking. So you could be an IV plus PO to that goal of 1.5 to 2 times maintenance. But oral is always preferable to me, provided that you have adequate hydration, provided that you have good urine output, provided that your BUN and creatinine do not continue to increase.
Okay, Dr. Maqbool, this has been a very good conference. We are so grateful with this, and we have for you this acknowledgement for your participation as professor in our continuing medical education program at the Colegio de Pediatría Nuevo León. This Constance, we will send you, and we hope you to receive as soon as possible.
Thank you very much for allowing me to participate, and I look forward to participating and helping you in the care of your patients in the future.
Thank you very much, Dr. Maqbool, again.
Thank you.
Victor,
have a good evening, everybody.
Thank you. Víctor Negrón está... Víctor, muchas gracias nuevamente. Ha sido una plática muy buena, ha despertado muchas inquietudes, ha habido muchas preguntas de parte de la audiencia. Y bueno, pues queremos también agradecerte nuevamente, Víctor, y sabemos que tienes todavía por aquí algún mensajito para nosotros.
Sí, gracias a todos, gracias a los participantes. Como dijo el doctor Maqbool, estamos en toda la disposición de poder ayudarlos con cualquier tipo de casos que tengan, cualquier duda, pregunta respecto a educación, con muchas ganas le podemos ayudar. Y esperamos que esta, como dije antes, no sea la primera, sino que sea una de muchos eventos que podamos hacer en conjunto con el Hospital de Niños de Filadelfia. Muchas gracias, y es un honor y un placer para nosotros el poder participar y apoyar este evento. Gracias.
Hay una pregunta aquí también, Víctor, que me gustaría mucho que nos contestaras. Hay una doctora que pregunta cuál sería la vía para presentar a un paciente o para enviar a un paciente al Children's Hospital of Philadelphia o consultar desde México con algún, para tener alguna orientación, ¿verdad?
Nosotros tenemos un equipo que trabaja y maneja todos los casos en español. Yo te puedo hacer llegar el número de teléfono, y te puedo hacer llegar también el correo electrónico donde pueden enviar el caso. Pero también, si le puedes facilitar mis contactos, o Juan Manuel le puede facilitar los contactos a la doctora, con mucho gusto. Si ella me envía un WhatsApp a mí, yo la puedo ayudar, y podemos ver el proceso con mucho gusto, no hay problema.
Vamos a pedirle a la doctora Adriana Garrido que se comunique con nosotros y para brindarle ese contacto que amablemente nos proporcionas. Te agradecemos nuevamente, Víctor, y nuevamente agradecemos al doctor Maqbool y a toda la audiencia. Pues muchas gracias, buenas noches, nos vemos la próxima semana en nuestra sesión del Colegio de Pediatría, y les recuerdo que nuestro Congreso Internacional serán los días 16, 17 y 18 de septiembre de este año en la modalidad virtual 100%. Muchas gracias, buenas noches, que descansen.